Hi, this is Jason Burke, and I wanted to share with you a copy of a presentation that I gave at the Healthcare Analytics Symposium in Chicago in July of 2014 called Creating the Competencies for Sustainable Innovation. I delivered one of the opening keynotes for the first year of this conference a couple years ago, and I used my time then to talk about the opportunity for more disruptive approaches to analytics, which recently became its own book. So when I got asked to come back this year, I thought this would be a great opportunity to give an update on that, particularly as it relates to some experiences in implementing those concepts through my work in a health innovation center at the University of North Carolina, Chapel Hill. I know most of you may not have had the opportunity to see the original presentation or read the book, so I won't make any assumptions about that today, but if any of you are interested in going back and hearing the original presentation, I provide a link at the end of the talk where you can do that, as well as get a copy of these slides. Now, I should start by apologizing for what may be a somewhat misleading title. I'm not going to be talking about how to make healthcare greener. I actually don't know the first thing about carbon footprints and renewable energy. The title for this talk is more of a reflection of what I see as a highly pervasive set of challenges in healthcare today, namely that we lack consensus on how to become more data-driven. To be sure, we're doing more analytics today than we've ever done before, but I would argue that we're not doing them very smartly. So my hope today is to share with you some ideas on how to make analytics smarter and hopefully position analytics to provide a very high-octane fuel for innovation, however you define innovation. Now, it might be hard to say in the context of a presentation like this, but in my opinion, I think our industry struggles with analytics. To understand those struggles, I think it's useful to acknowledge the scope of what we're really asking analytics to address. We're striving to use analytics today for three fairly different spectrums of insights. Institutions like mine, academic medical centers for example, we take on projects that vary from pure research projects with potentially long time horizons, all the way to more immediate quality and process improvement activities on the front line of care. In terms of reimbursement models, much of the industry now has a mix of traditional fee-for-service reimbursement as well as value-oriented care models. And medical practitioners look for analytics to help in making decisions that really run the gamut from very large groups of patients all the way down to the 53-year-old moderate risk male sitting in the waiting room. To cover all of those bases is a very tall order, and a person could easily argue that the scope is too big to be successful, but I don't actually believe that's true. My work over the past few years has led me to believe the opposite, that it's possible to develop a single, comprehensive analytics strategy that covers all three of these spectrums of analytical insight. I think it's possible, and not only that, but I think it is fundamental to actually transforming healthcare. But in order to describe that for you, I'm going to need to describe in more detail why we don't already have what I'm talking about. So to get started, I'd like you to go on a brief mental journey with me. If you're willing, I'd invite you to close your eyes for a moment and imagine sitting in your seat on a commercial airline that is taking you someplace nice, Hawaii maybe. You're buckled in, ready to take off, and the captain comes over the intercom to welcome you on board, and the pilot says something like, "Our flying time this evening is expected to be right about 4 hours. We'll be taking off to the west towards those very large mountains in pretty heavy air traffic, traveling at over 350 miles an hour. For those of you wondering how we manage that as pilots up here, our cockpit has no less than 187 different gauges that the two of us have to monitor. They give us readings once every hour about what the situation was like 45 minutes ago. The cabin doors will be closing soon, so if anyone needs to exit the plane, now is your chance." Now, hopefully the point of that story is self-evident. You cannot manage what you cannot see. I would get off of that plane, and I suspect many of you would get off of that plane, and yet we trust the health and well-being of patients every day to infrastructure that basically provides a comparable level of information utility. So you cannot manage what you cannot see, and our current trajectories in healthcare require us to see a lot more. If the trends towards value-based reimbursement, risk delegation, and population health represent long-term changes in health delivery, there are some not so subtle implications in terms of the way we think about analytics. For example, the business processes associated with value-based care delivery and management do not simply produce data, they are driven by data. Unlike the way we often think about health IT topics like EMRs, which are often running in parallel to the actual care of patients, in these care delivery and reimbursement models, data and insights are not just artifacts of the business process, they are the drivers of the business process. Frontline staff are not simply capturing data. Much of what they do, the activities they undertake, the decisions they make on how to allocate resources, even the data they collect, all of this is largely determined by other data, not simply by policy and practice. Take a look at the slide and this small subset of ACO processes and notice how many of them have data interdependencies. And as you do that, notice also that many of them are now time sensitive, meaning that they operate much closer to real time. Monitoring and managing risk, quality metrics, and population cohorts, these are not things that can be done effectively on a monthly or quarterly basis. They require data, systems, and processes that are responding more nimbly to a real-time flow of information. So these processes are data and insight driven, and they require greater timeliness to the flow of information. But there's one other attribute that they share, which is subtle, but I also think is important. They require closed loop insights, meaning that it is not enough to decide what should happen. You have to also know whether it actually did happen and the corresponding result. For example, if I refer a patient to a specialist as a means of mitigating that patient's health risks, if the referral is never processed and the patient never sees the specialist, I've done nothing to manage the risk. So the business processes can no longer be handoffs. It has to be a closed loop process of knowing not just what was supposed to happen, but what actually did happen. So these three attributes of our business processes, data-driven, timely, and closed loop, really suggest we need some improvements in the supporting infrastructure for delivering care. Now, for purposes of the discussion today, I'm going to lump those improvements into three categories of enhancements. Improvements to the base process and technical infrastructure we use to run healthcare, improvements in the analytical methods that we use, and growth in our capabilities, acquiring higher value business and technical capabilities that will allow us to more easily and effectively innovate. Now, I snuck back in that green sounding word sustainable again, and I would like to take a moment to share with you why I picked that particular word. One of the hardest things for me to hear on a day-to-day basis is how healthcare providers and payers cannot afford to invest in health analytics. It's hard because I know how most of their analytics projects work. An executive has a question. To answer that question, a small project team is formed to do an analysis. They spend weeks to months going around gathering up data, cleaning it, trying with limited success to document exactly what the data means. They then spend a few more weeks doing an actual analysis. Not too long, because it took so long to get the data ready that there isn't a lot of time for the analyses. The analyses themselves will usually be retrospective, descriptive statistics of what has happened in the past. They'll offer very little insight into what could happen, should happen, will likely happen, or how to make the best things happen. A report will usually get created, which is read by usually less than a dozen people, or maybe presented in a meeting. And when that little history lesson is basically finished, and let's not kid each other, that's basically what it is, it's a history lesson. When that's finished, all of that work is shelved, never to be used again. And when the next question emerges, we start all over again. Now, as long as we treat analytics as project-specific, disposable work, we are wasting time and money in a system that cannot afford lost time and money. Now, the reason this cycle exists is because most organizations have shortcomings in at least one of these 6 components of sustainability. For example, many providers have extensive infrastructure investments, but there's often a conspicuous lack of an enterprise architecture. Data assets are often assembled into business intelligence structures because those structures emerged from BI and web reporting tool requirements, but no one has actually modeled how to create data sets that are suitable for analytics as opposed to business intelligence. I won't take the time to go through all of these components, and the subcomponents are only a partial listing, but hopefully you get the idea. If you want to build a plan for a smarter infrastructure suited to analytics, you need to look holistically at capability and competency gaps. So that's the first category of making medicine smarter, sustainability. I'd like to now talk about the second category, which deals with the portfolio of analytics available to any organization. In healthcare today, analytics are often carried out in silos along a continuum between business analytics, things like financial reporting, and clinical analytics, which focus more on medical assessments like safety and efficacy. Analytical applications that exist at either end of this spectrum are fairly easy to acquire as the problem spaces are well understood. But as you move towards the middle, as you look to link financial and clinical data dimensions together, the complexity of the problem space grows more difficult. It's obviously important to understand that complexity, but it's also important to understand that the actual portfolio of analytical needs is growing beyond this taxonomy, and it requires integrating perspectives that historically would have existed in analytical silos across an organization. Now, where this is headed is a more consistent information architecture than what we have today. If this information hierarchy that's depicted on this slide seems like it should be a no-brainer, bear in mind that this does not reflect the way most providers and payers today are purchasing and developing their analytical portfolio. Patient registries, for example, are most commonly deployed in 3 ways: as standalone custom applications, which may just be a spreadsheet, niche applications that provide little to no interoperability, or embedded within EMRs, which also tend to struggle with interoperability. So, for example, there's no easy way analytically to cross between the clinical end of health outcomes for those patients and the financial end of cost accrual and ultimately value delivered. Nevertheless, the trick, if there is one, is not in the software per se. The challenge is in creating an information model that provides interoperability across multiple types of data and insights. So what are those? That brings us to the third and final category, which is capability maturity. This slide shows the 4 main dimensions of data that we have in healthcare. Clinical data such as EMR data, financial data such as cost and revenue, administrative data such as quality and efficiency, and behavioral data, which for patients includes things like consumer data. Within each type of data, the use of analytics can be characterized from a very small scale of ad hoc analytics, kind of like the story I mentioned earlier, all the way up to analytics that span all of the systems and processes across an enterprise. So that seems fairly straightforward, right? 4 data types ranging from a single guy doing a project all the way to strategic performance management. So why do we not have all that covered? The analytics today generally suffer from 4 underdeveloped capabilities, 3 of which you can see on this slide and 1 of which I'll have on the next slide. The first shortcoming is an over-reliance on the inner circles, analytics of limited scope and impact. And we tend to do that, quite frankly, because smaller is easier. The second shortcoming is a tendency to develop analytical models using only one of these 4 perspectives, clinical, financial, administrative, or behavioral, at one time. And we do that because, to use the color metaphor here, one color is easier to do than a blend of colors. Now, because we tend to do small scope and single colors, the third shortcoming is that analytical models rarely reflect the natural interdependencies between these four perspectives. We rarely, if ever, see the whole spectrum of color, if you will. Even though I would bet virtually everyone who's listening to this would agree that what we ultimately experience on a day-to-day basis in healthcare is the result of a complex interaction of these four data forces. Now, the fourth shortcoming relates to the quality of the questions we're asking. Our industry lives today in the lower left of this graph. We can't survive there, but we live there. We cannot build a value-oriented, economically sustainable healthcare system by focusing our efforts on reporting metrics of things that happened 6 months ago. Going back to our airplane story earlier, how many of you would want to be on a plane where the pilots did not have the insights needed to predict fuel consumption? We need to be asking more sophisticated types of analytical questions on a routine basis, not as a series of one-off, non-scalable projects. Progressively moving upward in this maturity towards being able to effectively model and predict future health outcomes and costs, and developing approaches for influencing and optimizing those particular outcomes. So in a lot of ways, this is about evolution. I've discussed these three categories across the top as if they're independent, and of course they're anything but independent. Improving the sustainability of your infrastructure is part of capability maturity, and as your capabilities mature, you're able to take advantage of more sophisticated forms of analytics. So I've just listed a few before and after capabilities on this slide, but I suspect you can pretty easily envision more. Any reasonably complete list of capabilities needed across healthcare today, even if you were just looking at something like population health, is a pretty big list, and I didn't want to put up a bunch of eye charts. But if anyone's interested in seeing a more detailed view of this kind of capability maturity, the link at the end of the presentation will take you to a website where I've posted some additional information on that. So we've talked about sustainability, we've talked about capability, but we still need to cover innovation and how we learn the improvements we need. I was reminded of our current state of health analytics with a research study recently published in the journal Cognition. The researchers compared young children and adults on their ability to learn causal relationships and generalizable inferences. And what they found was really interesting to me. Children are less biased by prior assumptions and pay more attention to current evidence when learning new causal relationships. It turns out that children are much more flexible learners than adults. If you've ever had the sensation of a child knowing how to use new electronic devices better than you do, this study actually provides a great experimental model for why that's the case. Here's a wonderful quote from the paper. If we say that better learners are people who make correct inferences more often when they are faced with common and familiar situations, then the advantage goes to adults. On the other hand, if we focus on how quickly learners assimilate new information and update their beliefs and come to understand novel situations, then flexibility, whether it's due to less entrenched ideas about the structure of the world or an exploratory approach to updating beliefs, is a marker of better learning. For the statisticians that may be listening, there's a lengthy discussion in the paper of the applicability of Bayesian hierarchies to these cognitive processes. Almost all of it was over my head, which, based on the paper's primary findings, probably says something about my age. But nonetheless, I raise this because for an industry that has only relatively recently embraced the electronic collection of data, it's surprising how entrenched we are in thinking about how to use data and analytics. There are a surprising number of projects and initiatives that are pursuing transformation by doing the exact same things we've been doing for the past 10 to 20 years. I developed this chart to facilitate both business and technical conversations about innovation investments like health analytics. The y-axis, the vertical axis, describes the business goal that you want to pursue. Are you trying to create an incremental improvement to the status quo, which is in box 1? Are you trying to build a new component to your existing operations, or are you trying to transform the current operational model? The x-axis, the horizontal axis, describes what methods or techniques you are thinking of employing to pursue that goal. Are you using common, everyday approaches? Again, box 1. Are you taking something that is well-defined but not widely used yet? Or are you creating something completely new? When considering this in the context of a health analytics project, some of the value is in just reaching agreement on what you're doing. A lot of times when people hear advanced analytics, they start thinking column 3. And of course, in a lot of cases, it is column 3, but depending upon the business goals and needs, it may be that the techniques needed are actually in columns 2 or even 1. Another issue that'll probably be evident as you review this is that the value of the innovation investments, as well as your likelihood of success, are not equally distributed throughout this chart. For example, box 7 is hard. It's really hard. And box 3 usually has a bad return on investment. Now, of course, innovation can occur in any of these boxes. And I think when thinking about innovation, I really like to think about innovation and learning basically going hand in hand. So I'd like to ask you to consider a fairly basic question, which is, are your health analytics actually on a solid path for creating a learning health system? Now, the term learning health system is kind of loaded. It's been used for quite some time, and though no one seems able to define exactly what one of these are, the concept still resonates, I think, with a lot of people because we know, whether we can draw a diagram of it or not, that there is a lost opportunity in all of this data and computing power we have today. We see care that doesn't work. We see how long it takes to bring improvements into routine delivery. We know the difference between putting data into EMRs and getting better intelligence from that data. So we don't really have to agree here today what it looks like. I'm just asking, is there a real plan for how you're going to exploit all of this information we're collecting to personalize and optimize care delivery? Said another way, are your analytics designed to grow your understanding of the factors, relationships, and interdependencies that actually determine health outcomes and costs, or are they just delivering reports and checking boxes? The reason I think the idea of a learning health system is a useful concept to discuss is that learning as a psychological discipline is a byproduct of a complex interaction between things like facts and experiences and the contextual information associated with those facts and experiences. It's not just about acquiring the new facts. Actually, facts are only a small portion of learning. Learning is actually process-driven. It's associative. It occurs iteratively. It involves testing and often even forms of play. You cannot find learning in a report. Learning is the byproduct of a process, and that process is contextual. If you don't have enough information about context, you can't actually learn. So my learning health system question is really this: do you have a process by which you are creating new improvements through an iterative synthesis of facts, experiences, and context? If not, analytics can help, and one of the reasons to undertake the journey I've been describing so far is to create that learning health system. Now, I'd like to share with you one example of how analytics can fuel a learning health process. This diagram represents a framework we've developed for creating an advanced analytics learning health model in the area of population health. The basic idea is that any population health program has at least two phases: the assessment of the as-is state, which is on the right-hand side of this dial, and the monitoring of the program once it's up and running, which is on the left-hand side of the dial. It doesn't really matter what the specific population health program looks like, whether it's focused on diabetes or renal care or what have you. There are a series of questions that will always be asked. What is the current population's risk, for example, which is at 1 o'clock on this dial? How does the population vary by care setting, which is at 2 o'clock on the dial? So you can kind of work your way around the clock. Each question can be asked using an analytical maturity model, starting with the basic descriptive statistics down in the lower left-hand corner of that maturity model, and moving progressively into the upper right, into things like predictive modeling. Now, once the program is up and running, the monitoring phase kicks in. Since we developed this analytical approach using the ideas of reusable data and analytical assets, some of the pillars we've been talking about so far today, what we monitor operationally not only aligns to what was assessed and planned, but can be used to iteratively refine the assumptions in the models. So, for example, if we thought patients would follow a particular risk profile, for example, did they? Who didn't? And I don't mean who in terms of the specific patient. What do patients look like who don't follow that particular risk model? How can we adjust our model to account for what we now see in the real world? In this way, we have a closed loop process, plans and estimates being iteratively refined based on real world experiences using a common set of data and analytical infrastructure. So we can actually tune our analytics over time. They learn and we learn, and we get iteratively better and better. Now, there's an implicit assumption in that process, and that assumption is that we are willing to rely on real-world data to offer insights on how to improve healthcare. And I have to tell you, I don't find that as a broad foregone conclusion. If you look at the way we manage innovation today, healthcare really focuses on two analytical scenarios. The first is founded in the scientific method, of course, and focuses on controlled empirical studies we usually call clinical research. The other is founded in operational efficiency concepts like Lean and Six Sigma, and we usually call those something like quality improvement. Now, these are probably familiar to anybody who's really been working in healthcare for any amount of time, but there is more to this picture. We don't really have a name for it yet, at least not one that everybody agrees on. Some people call it pragmatic research or pragmatic clinical trials. Some people call it data sciences or big data. I don't really care what you call it, but it operates according to a different set of constraints. It accepts that we may not easily be able to always establish causality, and that's okay because we may not need to know why something is true in order to know that it generally is true. And I believe this approach, which is an approach really founded in the real-world experience of healthcare, can offer really transformative insights because it's able to supplement our accepted conventions of hypothesis testing and process improvement with patterns and relationships that would otherwise go untapped. So I'll leave you today with a specific example of this. Readmission prediction is one of the most widely cited areas of analytics work today for obvious reasons. Like perhaps some of your organizations, our method for assessing readmission risk has historically been a calculator that categorically assigned patients to a 3-tier risk stratification based on a decision tree. We recently undertook a collaboration to look at alternative methods that might offer a little more sophistication than that. Take a look at the two patients here and formulate your own hypothesis around which patient has a higher risk for readmission. So as it turns out, both patients are actually at a high risk of readmission. But the interesting points are in digging a little deeper. You see, the old readmission decision tree would have classified both of these patients as low risk. Why? Because the factors that elevated their risk didn't happen to be in the decision tree. It also would have triaged these two patients the same because the risk stratification was categorical. It didn't discriminate as to how risky is risky. So why is patient 1 at a greater risk of readmission than patient 2? I'm guessing if there are any clinicians that are watching this, they may have a hint without necessarily knowing anything about the analytics. The answer is that patient 1 had their albumin tested. The fact that a clinician ordered an albumin test at all for a bronchitis diagnosis indicates that there's something else going on, the something else currently being undefined, and therefore representing risk. The model noticed more than the clinical diagnoses and the results. It noticed the process, the pathway. Yes, the patient's albumin is normal, that's fine, but somewhere there's a physician with a question about this patient that prompted that albumin test, and that's a question that has not really been clarified in the patient's chart as a diagnosis yet. And until we know what it is, whether anyone's actually documented the condition or not, this patient is indeed at higher risk. So using this new analytical approach, we actually see a threefold improvement in predictive power just off of the prototype. So you can't really get that level of performance improvement by doing the same things you have been doing. It actually requires all of the categories that we've covered here today. It requires a sustainable infrastructure, allows you to model and score risk in near real time. It requires a broader set of capabilities in both analytical methods and data, and it requires a willingness to look beyond the status quo quality metrics towards opportunities for real innovation. I know I've covered a lot of ground here today, but I just wanted to give you some ideas on these concepts of sustainability, capability, and innovation. And I'll refer you to the book and the website here if you're curious about learning more about any of these topics. Thanks a lot.